This talk is intended for the clinical neurophysiology fellows at Nicholas Children's Hospital. It is the first talk about neonatal EEG. Neonatal EEG is one of the basic tools we have to evaluate the neonatal brain. This talk will have two parts. The first part will be conducted in a conversational format, and the second part in a question and answer format. During fetal life, the brain goes from a rather smooth organ at 21 weeks conceptual age to a quite rugged organ by 40 weeks. This transformation yields age-specific EEG findings. These findings allows us to determine the patient's brain age, which corresponds to conceptual age with a margin of error of 2 weeks between 28 and 34 weeks, and with a margin of error of 1 week between 34 and 40 weeks in very well-controlled studies. The reliability of predicting brain age based on age-specific EEG findings has led some neurologists to suggest that in a clinical setting, it is better to read neonatal EEGs without knowledge of the conceptual age of the neonate at the time of the study, so as not to bias oneself. And then, once an unbiased brain age has been attached to the record, to check the conceptual age provided by the obstetrician. If they do not coincide, either the conceptual age estimated by the obstetrician is wrong, or there is something wrong with the neonatal brain. In addition to determining brain age, neonatal EEG is fundamental to detect unexpected pathology such as seizures. Neonatal EEG may help time the onset of a brain injury and help prognosticate the impact of brain injury. The purpose of this lecture is to talk about safety, technical issues, and background activity. Grapho elements, clinical related considerations, and conclusions will be addressed in a future talk on the subject. I will first address safety issue. You will find a full discussion about safety in another video in this channel. Here, I will make a few specific comments regarding safety and neonatal EEGs. Neonates are especially vulnerable to electrical injury, thus strict adherence to safety rules are necessary. Electrodes should be attached to the scalp after gently cleaning the skin at the electrode sites. Then the baby should be fed. The machine should be turned on and inspected before connecting the electrodes to the machine. Once the machine is on and no fault is found, the electrodes should be connected in the machine and not before. Machines used for neonatal EEG must have less than 10 microvolts of leakage current. Next, I would like to address technical issues. The impedance of the electrodes should be less than 10,000 ohms and be within 20% difference of each other. This should be achieved by gently cleaning the skin under the electrodes, as we have just previously mentioned. The duration of a neonatal EEG should be ideally 3 to 4 hours. That is from the end of a feeding to the beginning of the next feeding. In reality, they are recorded for about 30 minutes. It is important for the recording to include a full period of quiet sleep. It is also important to remember that in order to label an EEG invariable, the EEG should last for at least 60 minutes. The only activation procedure used in neonates are touch and noise. Photic stimulation is not done. When the recording takes place with the neonate in an isolate, the patient during the procedure should be loosely clothed. The humidity inside the isolate should be 50% or more, and the temperature inside the isolate should be 32 to 34 degrees Celsius. No colorium, no acetone should be used inside an isolate. Currently, most EEGs are done on babies kept in warmers. When the EEG is done in a warmer, the skin temperature should be kept at 36 degrees Celsius. Noise should be kept to less than 60 to 75 decibel hearing level. Electrode placement in neonate is fully discussed in another video in this channel. The video is labeled Montage Part 3. The main difference between electrode placement in an older infant and a neonate is the use of AF3 and AF4 electrodes. This is done for two reasons. The first reason is that the frontal pole of the neonatal brain is considered less active, certainly at 28 weeks, but also at 30 weeks and even at 34 weeks of conceptional age. The second reason is that eye activity produces too much artifacts in the frontopolar electrodes. Except for what I have just mentioned, the rest of scalp electrode placement in neonate is the same as in older children. In this frame, I have introduced the figure of an infant's head with the bones removed. I have done this to show you the relation between electrode placement in the area of the brain under them. Take a few seconds to look at it. Stop the video if you have to so you can better appreciate that relation. The relation between electrode position and area of the brain survey is not much different than in older patients, as you can see. Notice the position of AF3. A drawback from using AF3 is that an electrode in this position is very vulnerable to cardiac artifacts. This has led some investigators to use F1 and F2 instead of AF3 and AF4. The recommended number of electrodes to be used in neonatal EEG is 21, certainly no less than 16. In addition to the EEG channels placed using the 10-20 system, we must use one ground electrode, which is placed over the forehead, two electrodes either on the mastoids or ears to be used as non-cephalic references, and one machine reference. This electrode is not placed at a 1020 system electrode site, nor at the mastoid or ears. It is placed close to FC, but not on top of the anterior fontanelle. The machine will not work without this electrode. The electrodes we have just mentioned, as well as other electrodes placed in the scalp using the 1020 system, should be run using a low frequency filter of 0.5 Hz instead of the 1 Hz as recommended for older patients. Higher frequency filter should be set at 70 Hz and sensitivity at 7 microvolts per millimeter. If possible, other biological signals listed in this frame should be recorded. I have added a figure to show you the sites of electrode placement for biological signals recording. Eye movements should be monitored using electrodes placed around the eyes. The setting for electrooculography electrodes should be at low frequency filter of 0.5 Hz, high frequency filter of 70 Hz, and sensitivity of 7 microvolts per millimeter. The right ocular electrode is placed 0.5 centimeters lateral and down from the corner of the right eye. The left ocular electrode is placed 0.5 centimeters lateral and up from the corner of the left eye. The right and the left ocular electrodes are then connected to the respective differential amplifiers through electrode 1 slot. The slot 2 of both differential amplifiers are connected to a single mastoid electrode. In this figure, they are connected to the right mastoid. With this arrangement, eye movements will cause the tracing from these derivations to go towards each other or away from each other. This phase reversal is the consequence of the positivity of the cornea and the relative negativity of the retina. On the contrary to eye movements that are always out of phase, brain activity will cause both channels to go in the same direction. The in-phase derivation with cerebral activity is the consequence of the tendency of the brain activity to be driven by a single maximal polarity resulting from vertical dipoles. In addition to extraocular movement monitoring electrodes, we monitor nasal flow using thermistors that record air temperature and airflow. The setting for airflow electrodes should be low frequency filter 0.1 Hz, high frequency filter 15 Hz, and sensitivity 15 microvolts per millimeter. Chin tone, which is monitored with 2 electrodes, should also be known. The muscle that most contribute to the activity present in these electrodes is the mylohyoid muscle. The setting for chin EMG monitoring should be a low frequency filter of 5 Hz, high frequency filter of 70 Hz, and a sensitivity of 7 microvolts per millimeter. In addition to eye movement, nasal and mouth flow and chin EMG we should also monitor the heart. The setting for EKG electrodes should be low frequency filter of 0.5 Hz, high frequency filter of 70 Hz, and sensitivity of 300 microvolts per millimeter. Chest and abdominal movement reflecting respirations should also be done. The setting for respiratory effort monitoring at the level of the chest and the abdomen should be low frequency filter of 0.1 Hz, high frequency filter of 15 Hz, and sensitivity of 50 microvolts per millimeter. The last biological signal that needs recording is limb movements. They are recorded by placing an electrode on the skin above the tibialis anterior muscle. The setting for leg EMG should be low frequency filter of 5 Hz, high frequency filter of 70 Hz, and sensitivity of 7 microvolts per millimeter. The computer screen must present 10 seconds or more at a time in order to be appropriate. The final section and the bulk of this talk is about neonatal EEG background activity. I will conduct this section in a question and answer format. The first question is, the age of a neonate estimated from the last day of the mother's last menstrual period until the time of the EEG is done is called A. Postmenstrual age, B. Conceptional age, C. Gestational age, D. None of the above. In this frame, I have represented a uterus. Now a second uterus bleeding. On top, I have represented a calendar listing the days of the weeks. The one corresponds to the first day of menstruation. Now I have introduced another uterus and a calendar with the number 2. The number 2 is there to indicate the second week. Now I have added a figurine to indicate the joining of the ovum and the sperm. This event usually takes place in the Eustachian tube during the second week of the menstrual cycle. Next, I have introduced a fourth uterus and a calendar on top of it to indicate the third week after the onset of bleeding. The figure I have just introduced indicates the birth of the baby. The calendar with the number 40 indicates the weeks that have passed since the mother's first day of the last menstruation began. The two more calendars indicate week 42 and week 44 after the first day of the mother's last menstruation. And the Sherlock Holmes I have added indicates the day the baby is being evaluated by the doctor. In this frame, I have represented a gestational age corresponding to the time between the first day of the last menstruation and delivery. In this example, the gestational age is 40 weeks. At the time the patient is seen by the doctor, that is 44 weeks after the first day of mother's last menstruation, the chronological or legal age is 4 weeks. But let's say that instead of being born at 40 weeks after the first day of the mother's last menstrual period, the baby is born after 38 weeks. Then we talk about a gestational age of 38 weeks, and at 44 weeks after the first day of the mother's last menstrual period, we talk about a chronological age of 6 weeks. Using this same scenario, we can introduce a new term. The new term is corrected age. Corrected age means the age in weeks that the baby would have been if the baby would have been born at 40 weeks. In this case, at the time the doctor sees the baby corrected age is 4 weeks. The 2 weeks that correspond to the time between having been born and the time the baby should have been born is subtracted from the chronological age. Post-menstrual age corresponds to the time from the first day of mother's last menstruation till the time the patient is seen by the doctor, in this case 44 weeks. The term conceptional age, as it was used in the past and as it was used when all the data regarding neonatal EEGs was being collected back in the 1950s and 1960s, is interchangeable with the term postmenstrual age. But more recently, since an increasing number of pregnancies are achieved by artificial insemination, in which the exact knowledge of the time of conception is known, conceptional age is often used to indicate the age of the patient from the time of artificial insemination to the time the patient is seen by the doctor. In this example, it would be 42 weeks. During this talk, unless otherwise stated, when I give age in weeks or months, I am referring to conceptional age in the old-fashioned way. This is very important for you to remember, that despite the fact that I will not say conceptional age every time I mention weeks, it would be what I am referring to. So the answer to this question is D. Next question. Which of the following stages can be recognized at 37 weeks postconceptional age? A. Awake and asleep only. B. Awake, active and quiet, and asleep only. C. Awake, active and quiet, and asleep, active and quiet only. D. Awake, active and quiet, and sleep, active, quiet, indeterminate, and transitional only. Another peculiarity about neonatal EEG is staging. At 30-week conceptional age and before that, there are only 2 discernible stages. They are either awake or asleep. At 31 weeks and thereafter, there are 6. The distinction between awake and asleep for neonatal EEG is based on duration of eye closure. If the eyes are closed for more than 30 seconds, we say the patient is asleep. If not, we say the patient is awake. These 2 states, awake and asleep, are the only ones we are able to discern before the conceptional age of 31 weeks. At 31 weeks and thereafter, the awake state can be divided into quiet awake and active awake, and the sleep state can be divided into active sleep, quiet sleep, indeterminate sleep, and transitional sleep. So the answer to this question is D. Next question. Which is the least useful stage to evaluate the background activity of a neonatal EEG? A. Active awake. B. Quiet sleep. C. Active sleep. D. Indeterminate sleep. At 30 weeks and before that the interpretation of EEG activity during awake and sleep states has the same degree of benefit and challenges. At 31 weeks and after, some stages are better than others for EEG background interpretation. During active awake, the EEG is marred with artifacts. Periods of quiet awake are usually very short, too short to arrive to any definite conclusion regarding the status of the background activity. But when long enough, their evaluation is very useful. The EEG activity during indeterminate sleep is rather unpredictable. Transitional sleep periods, that is, the brief periods of a sleep stage that occur when active sleep becomes quiet sleep and vice versa, are very short, but at times these periods may denote significant background pathology. So we are often left with active and quiet sleep stages as the best periods for background analysis. So the answer to this question is A. Next question. Which of the following behavioral parameter is not a reliable indicator for sleep staging at 35 weeks conceptual age? A. Limb movements. B. Respiration rate. C. Eye movements. D. Shin EMG. Limb movements become reliable to distinguish active and quiet sleep after 28 weeks conceptual age. Nasal flow after 31 weeks. Extraocular movements at 32 weeks. Shin EMG becomes reliable at 40 weeks conceptual age. As you can see in this figure, published in the same book as from which the data I just previously gave you was collected, has a slightly different bend to what we have just mentioned. In the y-axis of this figure, the number represents the reliability, 4 being most reliable. That is reached by all parameters at 3 months conceptual age. From this chart, it appears that at 28 weeks or at any age, body and eye movements are the most reliable indicators of behavior, and Shin EMG is the worst. So the answer to this question is D. Next question. An epoch is defined as having irregular respirations if the respiratory rate varies more than 10 cycles per minute. A. True. B. False. An epoch is defined as having regular respiration if the difference between the longest and the shortest respiration is less than 20 cycles per minute. An epoch is defined as having irregular respirations if the difference between the shortest and the longest respiration is more than 20 cycles per minute. So the answer to this question is false. Next question. At what age can active and quiet sleep be first distinguished based on behavioral parameters? A. 28 weeks conceptual age, B. 31 weeks conceptual age, C. 34 weeks conceptual age, D. 36 weeks conceptual age. Active sleep and quiet sleep have very distinct characteristics. Limb movements in the form of sudden jerks will be present in active sleep but not in quiet sleep. Respiration rate will be irregular in active sleep and regular in quiet sleep. Rapid eye movements will be present in active sleep and not in quiet sleep. Shin EMG will be low in active sleep and high in quiet sleep. Between 31 and 39 weeks conceptual age, both of these 2 weeks included, Shin EMG is still not a reliable indicator of active or quiet sleep. Hence, most authors during this time consider concordance of 2 of these 3 parameters enough to label sleep active or quiet. From 40 weeks onwards, when Shin EMG becomes reliable, most authors consider the concordance of 3 of these 4 parameters necessary in order to label a sleep stage as active sleep or quiet sleep. If the 2 out of 3 rule is not met from 31 to 39 weeks, or the 3 out of 4 rule is not met after 40 weeks, then the sleep period should be labeled intermediate. So the answer to this question is B. Some authors will not use 31 weeks, but will use 32 weeks as being the better option. But since it is not present in this question, it's really not an issue. Next question. Which of the following parameters is the most reliable to distinguish quiet from active sleep? A. Limb movements, B. Respiration rate, C. Eye movements, D. Shin EMG. The most reliable parameter to distinguish active from quiet sleep or vice versa is respiration, which becomes reliable at 32 weeks. So the answer to this question is B. Next question. Rapid eye movements have a rise time of 1 second. A true, B false. Slow eye movements, often called SEMS, and rapid eye movements, often called REM, are easily identifiable by eyeballing them, as you can see in this frame. Yet, there is no agreement among different publications as to their exact dimensions. In Ebersol's book, the slope of rapid eye movement is said to be from 50 to 200 milliseconds. And its duration less than 1 second. Slow eye movements are defined as having a slope of more than 500 milliseconds and lasting more than 2 seconds. In the manual introduced in this frame used for sleep scoring. Rapid eye movements are defined as those lasting less than half a second, and slow eye movement are classified as those being more than 500 milliseconds. Regardless of the definitions, rapid eye movements are associated with active sleep, and slow eye movements are associated with drowsiness. So the answer to this question is B. Next question. Between 31 and 39 weeks conceptional age, how many is the least number of parameters needed to be in concordance to establish active or quiet sleep? A, 2 of 3, B, 3 of 3, C, 2 of 4, D, 3 of 4. Between 31 and 39 weeks conceptional age, most authors consider that the concordance of 2 of the 3 parameters in this frame are enough to label an sleep period as active or quiet. From 40 weeks onward, most authors consider that the concordance of 3 of the 4 parameters in this frame are necessary to label a sleep period as active or quiet. So, based on behavioral parameters, from 22 to 30 weeks included, sleep can only be divided in awake and asleep states. From 31 to 37 weeks, according to some, and from 31 to 39 weeks, according to others, sleep can be divided into quiet and active sleep based on 2 of 3 concordant parameters. And from 38 according to some and 40 weeks according to others, sleep can be divided into quiet and active sleep based on 3 or 4 concordant parameters. So the answer to this question is A. Look at this frame and choose the best option. A, active sleep. B, quiet sleep. C, indeterminate sleep. D, none of the above. The way to answer this question is to label each biological parameter independently. Respirations are irregular. Limb movements are present. Rapid extraocular movements are present. And chin EMG is low. Then look at the conceptional age. In this case, the age is 39. This age requires at least 3 concordant parameters. In this case, all 4 parameters are concomitant. So the answer to this question is A. Next question. Quiet sleep becomes reliable identified by dash weeks conceptional age. A, 28, B, 31, C, 34, D, 36. When we spoke about technical issues, I mentioned that a neonate EEG should include a full episode of quiet sleep. This is only an achievable goal after 31 to 32 weeks. This chart represents the percentage of active, quiet, and indeterminate sleep based on conceptual age. At 28 weeks, no quiet sleep is identified. About 45% of the sleep time is spent in active sleep, and the rest is indeterminate sleep. At about 31 to 32 weeks, quiet sleep becomes detectable, but its duration is very brief. By 34 weeks, quiet sleep increases mainly at the expense of indeterminate sleep. By 44 weeks, most of the sleep time is divided almost equally between active and quiet sleep. So the answer to this question is B. Next question. An EEG activity in a neonatal EEG of between dash microvolts should be classified as low voltage. A, 0 to 2, B, 3 to 25, C, 26 to 50, D, more than 50. EEG recording can be categorized based on voltage into inactive, that is when the voltage produced is less than 2 microvolts, low voltage range, that is when the voltage produced is between 3 and 25 microvolts. Some authors, if the amplitude is less than 10 microvolts, that is from 3 to 10 microvolts, they use the term very low voltage for that small group. EEG activity from 25 to 50 microvolts is called medium range activity. And above 50 microvolts, it is labeled high voltage range. So the answer to this question is B. Next question. Interburst interval is defined as a period in which activity is attenuated less than 25 to 50 microvolts peak to peak for 2 seconds or more. A true, B false. Interburst interval is defined as a period in which activity is attenuated minus 25 to 50 microvolts peak to peak for 2 seconds or more, and that is true. But not all agree with this definition of interburst interval in neonatal EEG. One of the reasons for this is that the number in this definition is a mathematical aberration. Still, this is the definition that is currently used by the Academy, so you will have to learn it. If I had my way, I would define attenuation based on the percentage of drop in amplitude from the preceding burst. Anyway, the answer to this question is A. Next question. EEG continuity is reached first during wakefulness. A true, B false. This chart is based on Luther's book. It does not define continuity or discontinuity. It simply shows that during REM sleep, a sleep stage that we have been labeling as active sleep, discontinuity is no longer present after 30 weeks. During wakefulness, discontinuity disappears by 34 weeks, and during quiet sleep by 44 weeks conceptual age. So the answer to this question is false. Next question. All authors agree on the maximal duration of the interburst intervals at different conceptual age. A true, B false. In this frame, I will present normal values correlating post-menstrual age with maximal interburst interval duration and interburst interval amplitude. This is from a 2013 report from the American Clinical Neurophysiology Society. Normal neonates less than 30 weeks post-menstrual age have interburst interval with a maximal duration of 35 seconds and an interburst interval amplitude of less than 25 microvolts. Normal neonates from 30 to 33 weeks have interburst intervals with a maximal duration of 20 seconds and an amplitude of less than 25 microvolts. Normal neonates from 34 to 36 weeks conceptual age, post-conceptual age, have interburst interval with maximal duration of 10 seconds and an amplitude of about 25 microvolts. Normal neonates from 37 to 40 weeks have interburst intervals with a maximal duration of 6 seconds and an amplitude of more than 25 microvolts. But that is not the only values given for the duration of interburst intervals. In Niedermeyer's book, The Longest Mean with Plus or Minus Standard Error, whatever that is, interburst interval duration in neonates that were normal at 3 years was presented. You can see it in this frame. It was about 15 seconds between 26 and 29 weeks conceptual age. That is, the duration of the interburst interval was 15 seconds in this age group. It dropped precipitously between 29 weeks and 33 weeks. And it hovered about 6 seconds from 35 weeks until 40 weeks. The same book provides a little bit different data in that they classify the interburst interval with no appreciable activity. So this chart represents the duration of those periods or those interburst intervals where there was no appreciable activity at all. The study found interburst interval with no appreciable activity lasting as long as 11 seconds at 26 weeks, as long as 6 seconds at 31 weeks, and as long as 5 seconds at 36 weeks. At 40 weeks, they found interburst interval of 2 seconds. In Stoker Pope book, they describe the usual duration of the flat periods to be 10 seconds by 26 weeks, 6 seconds by 35 weeks, and 4 seconds by 40 weeks. The same figure includes the duration of the burst, which goes from 4 seconds at 26 weeks, increasing steadily till about 6 seconds at 39 weeks. I find it interesting and useful that at about 35 to 36 weeks, the lines intersect, indicating the time when the duration of the burst outlasts the duration of the interburst intervals. So the answer to this question is false. Next question. What would make a neonatal EEG abnormal? A 29-week postmenstrual age with interburst intervals consistently lasting 30 to 35 seconds with amplitude of 10 to 15 microvolts. B. A 34-week postmenstrual age with interburst intervals consistently lasting 8 to 10 seconds with amplitude of 10 to 15 microvolts. C. A 38-week postmenstrual age with inconsistent interburst interval longer than burst. D. A 40-week postmenstrual age neonate with interburst intervals consistently lasting 4 to 6 seconds with amplitude of 10 to 15 microvolts. From the data that I have presented to you, I am unable to reach a sound consensus as to how long an interburst interval should be. Yet, every time I read a neonatal EEG, I have to make a decision, so I use the following criteria. In patients 37-week conceptual age or older, consistent interburst intervals longer than the burst is abnormal. Consistent interburst interval lasting longer than 6 seconds or with an amplitude of less than 25 microvolt is abnormal. In neonates of 36 weeks conceptual age or less, I use the following values. In a neonate less than 30 weeks, an interburst interval lasting more than 35 seconds is abnormal. I do not use amplitude as a parameter to decide abnormality in this age group. In a neonate from 30 to 33 weeks conceptual age, an interburst interval longer than 20 seconds is abnormal. Again, I do not use amplitude in this age group. In neonates 34 to 36 weeks conceptual age, an interburst interval longer than 10 seconds, I call it abnormal. I do not use amplitude in this group either. Using this criteria, I give myself wiggle room with the word consistent. If the background findings just mentioned are associated with other abnormalities, such as seizures or a normal grapho element, then my threshold for consistent abnormality is lower. If no additional abnormality is present, then my threshold for consistent abnormality is higher. In other words, for records to be read as abnormal based solely on the abnormal findings I just described, the findings have to be present throughout the whole record, whereas if other abnormalities are present, less portion of the record needs to be involved in order for me to label it as having an abnormal background. So the answer to this question is D. Next question. Which of the following EEG patterns are usually present during active sleep between 36 and 44 weeks postmenstrual age? A. Tracé alternate and low voltage irregular. B. Tracé discontinue and tracé alternate. C. Low voltage irregular and activité Majoni. D. All of the above. Not all agree on the definition of sleep EEG patterns. One definition of tracé alternate is the following. A normal neonatal EEG pattern. It is present between 36 and 44 weeks postmenstrual age, and it consists of bursts of 40 to 300 microvolts delta waves alternating with low voltage theta activity with an amplitude ranging from 25 to 50 microvolts. Burst should last longer than 6 seconds and certainly last longer than the interburst. Another definition of tracé alternant is very similar but adds that the duration of the burst should be 4 to 10 seconds and describes the interburst interval activity as consisting of theta and delta waves. As you can see in this table, tracé alternant defined simply as a normal activity with interburst interval lasting 6 seconds or less and with an amplitude of 25 microvolts or more, is present during quiet sleep from 36 to 44 weeks. Another EEG pattern recognizing the newborn is low voltage irregular activity. This activity is defined as a normal EEG pattern that occurs in full-term neonates. It consists of continuous 4 to 12 Hz rhythmic activity with an amplitude of 20 to 30 microvolts. As you can see in this chart, low voltage irregular activity is present during awake and during active sleep from 36 weeks to 44 weeks postmenstrual age. Tracé discontinue can be defined as a normal pattern in a preterm neonate. Tracé discontinue is characterized by bursts of high voltage activity ranging from 100 to 150 microvolts. This slow activity, which is in the delta range, is override by lower voltage faster activity. The bursts alternate with interburst consisting of low voltage slow activity. Burst and interburst intervals must be appropriate for age. A second definition of tracé discontinue is as follows. Tracé discontinue is a normal EEG discontinuous pattern encountered in healthy premature neonates. It consists of bursts of high voltage activity from 50 to 300 microvolts that is interrupted at regular intervals by low voltage activity. Looking again at the general chart, you can see that I have divided tracé discontinue in 3 subtypes. These subtypes are based on the upper limits of normal of the interburst interval duration. The first subtype has interburst intervals duration between 21 seconds and 35 seconds. It is present during awake and sleep between 22 weeks and 30 week conceptional age. Any activity with interburst intervals of longer than 35 seconds present during this time is not tracé discontinue. It is an abnormal discontinuous pattern. The second subtype of tracé discontinue has an interburst interval duration of more than 10 seconds and less than 20 seconds. This pattern is present during awake and quiet sleep between 31 and 33 weeks conceptual age. Again, any activity during these weeks with an interval of longer than 20 seconds is not a true tracé discontinu. It should be labeled an abnormal discontinue pattern. The third and last subtype of tracé discontinue has interburst interval duration of 10 seconds or less and an amplitude of less than 25 microvolts. I mentioned the microvolts in this subtype of tracé discontinue because this is what distinguishes it from tracé alternate when the duration of the interburst interval is less than 6 seconds. This subtype is usually present during quiet sleep at 34 and 35 weeks conceptual age. The same comments made for the other subtypes apply here. In addition, it is important to stress that the presence of shorter rather than longer interburst interval do not represent an abnormality. Activité Majoni has been defined as a normal EEG background pattern in neonates. It consists of continuous low to medium voltage 20 to 50 microvolts mixed frequency activity with the predominance of theta and delta and overriding beta activity is present according to some authors. Other authors have defined it as a normal EEG background activity in full-term neonates that consists of continuous 1 to 10 Hz, predominantly 4 to 7 Hz activity with an amplitude of 25 to 50 microvolts. This chart, as you can see, represents activité Majone, which occur during a week and during active sleep from 36 to 44 weeks. So the answer to this question is C. Next question. Which of the following EEG patterns are usually present during quiet sleep between 36 and 44 weeks postmenstrual age? A. Trace alternate and high voltage slow. B. Activité moyenne and tracé alternate. C. High voltage slow and mixed activity. D. All of the above. Tracé alternate, as we have already discussed, is present during quiet sleep from 36 to 44 weeks. It may persist all the way to 48 weeks. High voltage slow wave is defined as a normal EEG pattern activity in full-term neonates. It consists of continuous moderately rhythmic wave between 0.5 and 4 Hz, ranging from 50 to 150 microvolts. This activity has posterior amplitude preference. The posterior amplitude of the activity is higher than the anterior amplitude. As you can see in this table, high voltage slow wave occurs during quiet sleep from 36 to 44 weeks. Another pattern that we see in neonate is mixed voltage pattern. This pattern is defined by some authors as a normal neonatal EEG pattern present between 30 and 36 weeks conceptual age. It consists of a continuous predominantly theta wave with some intermixed delta and alpha. The amplitude of the waves alternate from one wave to the next. One wave will be from 20 to 50 microvolt, and the next one would be from 100 to 150 microvolts. As you can see, mixed voltage activity is present during active sleep from 31 to 35 weeks and during awake at 34 and 35 weeks. Activity major, as we previously said, occurs during awake and active sleep between 36 and 44 weeks. So the answer to this question is A. Next question. Which of the following EEG activity shows no evidence of discontinuity? A. Tracé discontinue. B. Tracé alternate. C. High voltage slow wave. D. All of the above. The activity that show no evidence of discontinuity are mixed voltage activity, activité major, low voltage irregular, and high voltage slow pattern. So the answer to this question is C. Next question. Which of the following EEG patterns occupies the majority of quiet sleep in a 43-week conceptual age neonate? A. Low voltage irregular. B. Activité major. C. High voltage slow. D. Mixed voltage pattern. Going back to the general chart, you can see that high voltage slow and tracé alternate are present during quiet sleep between 41 and 44 weeks. This graph shows the proportion of discontinuous recording and continuous recording starting at 32 weeks conceptual age. As you can see, after 36 weeks, the proportion of high voltage slow wave during quiet sleep increases. And by 43 weeks, most of the EEG during quiet sleep consists of high voltage slow wave pattern. So the answer to this question is C. Next question. The portion of an EEG of a 35-week conceptual age neonate demonstrating consistent intervals of 20 seconds should be labeled A. Tracé alternate, B. Tracé discontinue, C. Activité major, D. Abnormal discontinuous pattern. You have seen this chart before. It states the upper limits of normal. At 35 weeks, the maximal normal interburst interval is 10 seconds. So the answer to this question is D. Next question. Tracé discontinue interburst intervals amplitude is less than 25 microvolts. A true, B false. The black and white element of this frame is from an article published in 2013. The term discontinuous EEG is presented, and for it shows three options. Tracé alternate with an interburst interval amplitude of 25 microvolts or more. Tracé discontinue with an amplitude ranging from 0 to 24 microvolts, and burst suppression pattern with an interburst amplitude of less than 5 microvolts. A fourth option presented in this frame is abnormal discontinuous pattern. This occurred when the interburst interval are excessively long. This new frame summarizes these four patterns using the criteria that is accepted by most, but certainly not by all, electroencephalographers. This criteria says that tracea discontinua occurs in neonate less than 36 weeks. The background changes with the stimulation. The amplitude of the interburst interval is less than 25 microvolts, and the activity during the burst is normal. Tracea alternans occurs in full-term neonates, at times extending up to 48 weeks post-menstrual age. It is a reactive pattern. Interburst interval amplitude is above 25 microvolts, and the burst activity is normal. Excessive discontinuous pattern occurs at any age. Reactivity may or may not be present. Interburst interval amplitude is variable, and the burst activity is normal. Burst suppression occurs at any age. Most agree that there is no reactivity. Some consider that the interburst activity should be less than 2 microvolts, and the burst should be made of spikes and sharp waves. So, one thing in common to all tracea discontinuous, as I have chosen to define them, is the interburst activity being less than 25 microvolts. So the answer to this question is A. Next question. Which activity prevails during the first episode of quiet sleep of a full-term neonate? A. Tracea alternans. B. Mixed voltage pattern. C. Activity Mayon. D. High voltage slow pattern. The sleep cycle of a full-term neonate starts with the neonate awake. At the time, the EEG pattern is characterized by low voltage irregular activity or activity Mayon. The full-term neonate may go into active sleep with no apparent transitional sleep, or a brief period of transitional sleep may occur. During this first period of active sleep, the prevalent EEG activity is activity Mayon. After this period of active sleep, there is a brief transitional episode towards quiet sleep. Then quiet sleep appears. The prevailing EEG activity during this first period of quiet sleep is high voltage slow. Following a transitional sleep, the EEG activity will change. And at that point, while the patient is still in quiet sleep, the prevailing activity will be tracea alternans. This is followed by a brief period of transient sleep and a return to active sleep. The prevailing EEG activity during this second period of active sleep is a slow wave irregular pattern. So the answer to this question is D. Next question. Which of the following parameters shows highest concordance with EEG? A. Body movements. B. Respiratory pattern. C. Rapid eye movements. D. All of the above. The clinical parameter with highest concordance with EEG is respiration. Notice that the green columns for respiration and the yellow column for EEG are always at the same height. So the answer to this question is B. Next question. Dash consists of continuous moderately rhythmic activity with wave between 0.5 and 4 Hz ranging from 50 to 150 microvolts. A. Tracé alternant. B. Mixed voltage pattern. C. Activité Majon. D. High voltage slow pattern. Tracé alternant and tracé discontinue are characterized by alternating burst and interburst intervals. No such description is present in this question. Mixed voltage pattern consists of high and medium wave that are side by side, forming a continuous rhythmic activity of alternating amplitudes. Activité Majon has a bigger repertoire of brain wave frequencies than mixed voltage pattern. The voltage of this activity, that is of the Activité Majon, is in the medium range. High voltage slow pattern has a narrow repertoire of frequencies in the delta range, and most of the activity is in the 100 to 150 microvolts range. So the answer to this question is D. Next question. Please take a look at this frame and decide whether the activity is A, normal, or B, abnormal. The first step to answer this question is to determine the behavioral state of the epoch. Breathing is irregular. Limb movements are positive. Fast extraocular movements are present. Chin EMG is low. So we're dealing with active sleep. As you can see in this table, at 40 weeks conceptual age, during active sleep, two patterns may be present: Activité Majon and low voltage irregular. Activité Majon is a continuous pattern. Low voltage irregular is also a continuous pattern. The EEG activity in this epoch is a discontinuous pattern. So the answer to this question is B. Next question. Please look at this epoch and choose best answer. Respirations are irregular. Limb movements are present. Extraocular movements are present. Chin EMG is low. These parameters indicate active sleep. As you can see in this table, at 33 weeks during active sleep, the EEG activity present corresponds to mixed voltage activity. Mixed voltage pattern is a continuous pattern. The EEG pattern represented in this epoch is discontinuous. So the answer to this question is B. Next question. Please look at this epoch and choose best answer. They are on your right. The choices are tracé discontinue, tracé alternate, low voltage irregular, and activity major. The pattern present in this epoch is discontinuous. Since an abnormal discontinuous pattern and burst suppression are not among the choices were given, and low voltage irregular and activité major are continuous patterns, there are only two possible choices: tracé discontinue and tracé alternate. Since the interburst interval amplitude is less than 24 microvolts, the best answer for this question is tracé discontinue. Next question. Please look at this epoch and choose best answer. This frame has an epoch with discontinuous activity. Since an abnormal discontinuous pattern and burst suppression are not among the choices, and low voltage irregular pattern and activité major are continuous pattern, we are left with two choices. The first choice is tracé discontinue, and the second choice is tracé alternate. Since the amplitude of the interburst interval is more than 25 microvolts, and the patient has a conceptual age of 40 weeks, and is in quiet sleep, tracé alternate is the best choice. So the answer to this question is tracé alternate. Next question. Please look at this epoch and choose best answer. The figure I have just introduced in this frame has discontinuous patterns represented in magenta and continuous pattern in blue. The epoch here presented is continuous. Therefore, tracé alternate and tracé discontinuous can be excluded. High voltage slow activity has a consistent voltage above 100 microvolt, which is not present in this tracing. So the only other available alternative is mixed voltage pattern. So the best answer to this question is MVP, or mixed voltage pattern. Next question. Please look at this epoch and choose best answer. At 40 weeks, during quiet sleep, of the choice provided in this question, the only possibility is high voltage slow wave pattern. So the answer to this question is HVS, high voltage slow pattern. Next question. Look at this epoch and choose best possible answer. This question, as all the other questions, can be approached by looking at the options. It is always better to look at the options first before looking at the tracing, so you know exactly what are the possibilities. That is during an exam. Then eliminate as many choices as possible based on the presence of continuity or discontinuity. Since in this epoch the EEG is continuous, tracé alternant and tracé discontinue can be eliminated as possible correct answers. Next, you look at the age if it is provided. At 37 weeks, low voltage irregular and high voltage slow waves are appropriate patterns. Since the patient is awake and high voltage slow is a pattern that is only present during quiet sleep, and in addition the voltage presented in this epoch is low, so the best answer for this question is low voltage irregular. Next question. Asynchrony during quiet sleep is normally present at 36 week conceptual age. A true, B false. One way to go about determining synchrony or the lack of it is to see if during more than 75% of the tracing, the burst in both hemispheres start and end within 1.5 seconds apart. If so, we call the tracing synchronous. If less than 75% meet this criteria, we call the record asynchronous. Another way is to choose 5 minutes of discontinuous background and see if the burst from both hemispheres starts and ends within 2 seconds of each other. This figure represents the degree of synchrony and asynchrony using the later criteria at different conceptual ages. During REM or active sleep, during intermediate sleep, and during non-REM sleep or quiet sleep. As you can see, at 26 weeks, during indeterminate sleep, there is 100% synchrony. Some degree of asynchrony was reported at 32 weeks during REM sleep. This finding is difficult to reconcile with the fact that during REM sleep or active sleep, there's no discontinuity present. At least, normally there's no discontinuity present. But I included there because that was the way it was presented in the study. Finally, during non-REM sleep, asynchronicity is certainly present at 32 weeks and still present at 38 weeks and is gone by 40 weeks. Another interesting characteristic of synchronicity is its property to first appear in the central region of the brain, that is, of the scalp, and then to be seen in more peripheral regions. In this chart, I am illustrating the presence of interhemispheric burst synchrony. Interhemispheric burst synchrony should be 100% between 22 and 26 weeks, and it should also be 100% after 40 weeks. Synchronicity should be present during most of the tracing from 34 weeks onwards. Remember that synchronicity was defined based on the presence of a discontinuous pattern, and therefore it should only be present during tracé discontinue and tracé alternate. So the answer to this question is true. Next question. Consistent lack of reactivity to pain after 32 weeks renders an EEG abnormal. A true, B false. Reactivity, defined as a change in amplitude of the background activity, depends on conceptual age and the mode of the stimulus. From 27 to 31 weeks, absence of reactivity to any modality is normal, since up to 10% of EEG of normal neonates do not respond to pain. From 32 weeks onwards, consistent lack of reactivity to pain is abnormal. After 37 weeks, lack of reactivity to noise is abnormal. It's interesting that light in the neonate very often behaves like an arousal-inducing stimulus, although at times it also produces photic responses that may be symmetrical or asymmetrical. So the answer to this question is true. Next question. Reaction to pain should be tested in all neonatal EEGs. A true, B false. It is a good idea to initially evaluate the reactivity of a neonatal EEG using noise. The best way to do this is by clapping by the side of the neonate. If a change in amplitude coincides with the clapping, then reactivity is considered present and no further testing is necessary for that regard. If there is no reactivity to noise, then we must check for reactivity to pain, first with minimal pain and then increasing the level of pain to a reasonable level. If reactivity is present, then no further testing is necessary. If there is no reactivity after the first time we try it, then we need to consider conceptual age. If the patient is equal or more than 32 weeks, the lack of reactivity is abnormal. But if the neonate conceptual age is between 27 to 31 weeks, then it is important for us to determine if the lack of reactivity is consistent or not. If the lack of reactivity is not consistent, that is, if present at times and not during other times, I usually consider the record to be normal. If, on the other hand, I find that there's never a response, that is, every time pain is produced, there's no reaction, then I call it abnormal. EEG reactivity to single painful stimuli is depicted in this chart. It should always be present from 34 weeks onward. So the answer to this question is false. Next question. An asymmetry of over 50% limited to one sleep stage is abnormal. A true, B false. Interhemispheric background amplitude symmetry is judged by comparing the homologous brain areas in both hemispheres. EEG activity for homologous area should be rather symmetrical. Most authors would consider an asymmetry of less than 50% normal. Others even consider such an asymmetry, that is, an asymmetry of more than 50% normal, if it is not present in all stages. In this chart, I have used an asymmetry of less than 50% as normal throughout. This is regardless of the conceptual age of the neonate. So the answer to this question is false. Next question. When can we distinguish between active sleep and quiet sleep based only on EEG activity? A. 29 to 30 conceptual age weeks. B. 31 to 33 conceptual age weeks. C. 34 to 37 conceptual age weeks. D. 38 to 40 conceptual age weeks. Purely based on EEG activity, awake and quiet sleep can be reliably distinguished from each other after 34 weeks conceptual age. Awake and active sleep can reliably be distinguished only between 31 and 33 weeks conceptual age. Quiet and active sleep can be reliably distinguished after 31 weeks. So the answer to this question is B. Thank you very much for your attention.